So I would like to start the presentation itself, and my learning objectives are just to review the most common phacomatosis or neurocutaneous syndromes, then to emphasize the most common differential diagnostic imaging features, and also look at the most useful method and then the whole imaging strategy for all phacomatosis, all the most common ones. What are the phacomatosis or so-called neurocutaneous syndromes or neuroectodermal dysplasias? Those are disorders of embryonic ectoderm structures because, as you know, the central nervous system and also the skin and eyes originates embryologically from the ectoderm. So that's a typical common feature for all of these dysplasias. And the typical concerning imaging are the benign tumors, many types of the benign tumors, most often multiple of them, and then slow progression from the childhood to the adult, and some of those tumors should have malignant predisposition, so it's a really important thing which we have to keep in mind. I would like to focus on four most common types of neurofibromatosis or phacomatosis. As I said, we have many other types, but the four ones are the most common. Those are neurofibromatosis, number or type 1 or 2. Type 1 is so-called von Recklinghausen disease. Then tuberous sclerosis or Brunevel-Pringle syndrome. Then Sturge-Weber syndrome, and then von Hippel-Lindau. As I said, we have many other, but those four ones are the most common. And concerning the imaging strategy at the central nervous system, the imaging method number one, of course, is MRI. And especially here, MRI with the contrast agent, with the gadolinium intravenous contrast. This is really important because, as I have already said, we should look at a different type of tumors. We should look at multiple tumors in multiple locations. So the application of the contrast is really necessary here. And of course, in some types, some type of regions, we should use, of course, the CT and other methods indeed. Let's start with neurofibromatosis, and especially with neurofibromatosis type 1. As you can see, we have many subtypes also here in the group of neurofibromatosis. However, type 1 and type 2 consist 99% of the neurofibromatosis itself. And if you look here, the type 1 von Recklinghausen disease consists 90% of all phacomatosis. So it's also important thing. But on the other hand, this type of neurofibromatosis is so-called peripheral. That means just the peripheral structures are affected, not central nervous system itself. Look that the CNS lesions have all just 15 to 20% of the patients, so it's not so interesting concerning imaging methods of the central nervous system. Typical are café au lait spots on the skin in adults or in children, of course, a little bit smaller, and then neurofibromas or plexiform neurofibromas peripheral. And on the skin, there are many lesions on the skin, like freckling under the arms or groin, and so on. And of course, also concerning the skeletal lesions, bone dysplasias. They are quite typical here, and that's why the CT should be really helpful here indeed. Concerning CNS itself, the most typical tumor is optic pathway glioma, it's pilocytic astrocytoma, but also other abnormalities like dysplasias of white matter and lesion nodules of the iris. This is my first case. If you look on the CT of the left side, the brain is quite normal, but if you look under the skin, there are many nodules, slightly isodense on CT, and looking on MR on T1 weighted image, this intensity is a little bit lower on T1 and higher on T2. And on CT, on the bone window and reconstruction, you can see dysplasia of the skull and surrounding dysplasia of the soft tissue on the MR imaging indeed here. So it's quite typical, and you can see here there is no involvement of the central nervous system. Not like this case, like this typical optic glioma. The most useful image and plane is coronal plane, and then you can use a FLAIR or T1. You can see here T1 after the contrast that the glioma is non-enhancing, which is typical, is just pilocytic astrocytoma. But the diameter of the optic nerve is here more than 1 centimeter, so is quite nicely detected and shouldn't be missed on even on non-contrast MR imaging. Other thing is a spinal canal, because we know we do have a lot of peripheral neurofibromas and plexiform neurofibromas. So if you look at the spinal canal, we definitely must apply contrast agent. If you look on the spinal canal here, we have one big plexiform neurofibroma and a small one here on the transversal plane, also quite small neurofibroma and really about 2 or 3 millimeters big, so that means definitely we have to use the contrast. And instead of that, we have also peripheral things going from the spinal canal, neurofibromas, and this is a CT, whole body coronal reconstruction, and we can see many tumors in the thorax, in the soft tissue here, in the pelvic region here. So we can use the whole body CT or a whole body MRI, of course. The advantage of MRI is absence of radiation. The CT is a little bit easier to do, so it depends what's available at the time. Neurofibromatosis type 2 is typical bilateral schwannomas of the 8 cranial nerves. This is MISME, multiple intracranial schwannomas, meningiomas, and ependymomas is quite typical. And which is important, this neurofibromatosis is called central, because as you can see, the involvement of the central nervous system is almost 100%. So it's quite more interesting for neuroradiology. Indeed. And the typical image here, T1 weighted image after the contrast, bilateral tumors. But if you look more frontally in the cavernous sinuses and suprasellar region, we can see many other enhancing tumors, which are schwannomas of the other cranial nerves. Another case is here, huge bilateral T1 low intensity, T2 mixed high low intensity, and enhancing after the contrast bilateral schwannomas of the 8 cranial nerves. But not only schwannomas, but also meningiomas and ependymomas. Here is on CT after the iodine contrast, many meningiomas throughout intracranial space, and this is MR of the same patient, and you can see the thickened dura enhancing after the contrast, many lesions here. It's interesting to see the small meningioma on the tentorium here, and very close by a huge schwannoma of the 8 cranial nerve here, and also ependymomas and astrocytomas of the spinal cord. So there are a lot of tumors of the central nervous system, and the same situation is in the spinal canal. If we look on T2, we see multiple hyperintense lesions in the spinal cord, which should be ependymoma, but also some dysmyelinization and dysplasias indeed. As we will see later in different syndromes, there are also some dysmyelinization, and after the contrast, a lot of meningiomas and also schwannomas inside the spinal canal. And the most useful protocol should be with T1 fat saturated after the contrast. You can see the nice enhancement of this huge schwannoma, and another one quite small in the lumbar region here, and another one also here on the transversal plane. So those are the most useful sequences. Concerning differential diagnosis, this is not so complicated in those specific syndromes. However, this one case is quite interesting, because it was the patient we just applied the contrast. I mean, we've seen bilateral tumors of close to the internal auditory canals. We've seen the tumor inside the spinal canal, so the suggestion was like it should be neurofibromatosis type 2, but it was germinoma, nicely seen, of course, on the different plane, on the sagittal plane here. in the typical region, and all these lesions were not the primary tumors, but they were the germinomas with CSF seeding throughout the intracranium and the spinal canal. So that should be kept in mind that those tumors which are seeding through the CSF should mimic those multiple tumors in this phacomatosis. So let's move to the second syndrome, and then that's tuberous sclerosis. The typical thing in tuberous sclerosis, typical tumor, is hamartoma. You can see multi-organ hamartomas, so not only the central nervous system, but also different organs, and then not only hamartomas, you can see angiomyolipomas, rhabdomyomas, leiomyomas, and different types of tumors. Concerning the central nervous system, the hamartomas should be cortically. They typically calcify, all the hamartomas should calcify. They non-enhance these cortical ones, and they have no malignant predisposition. Another regional subependymal nodule, subependymal hamartomas. Almost all patients has these cortical and subependymal lesions, and they also calcify, and they are close to foramen moneroid, or should be close, should be everywhere subependymally, but near the foramen moneroid, and they are enhancing. About 1/2 of them, 30 to 80%, you can see the range is quite high, enhancing, but this is not a malignant feature. This is really important to know. And the most typical thing is a giant cell subependymal astrocytoma. It also calcifies, as you can see on CT nicely. There's huge calcification. It should enhance on CT, or of course on MR indeed, and it's not malignant, but should do the obstruction of foramen moneroid with dilatation of the lateral ventricle. So it's also one thing which should happen. And then, as I mentioned, we should have angiofibromas, angiomyolipomas, and other. This is MR on T2 and T1 after the contrast of the patient with tuberous sclerosis. You can see a real high signal from the white matter, this low signal from calcification subependymally, and after the contrast, the enhancement close to the foramen moneroid here should be giant cell astrocytoma. Here the CT should be of use because the small calcification, as here, are of course nicely seen, and then we can compare MR and the difference, of course, on MR where the subcortical hamartomas are much more better seen than on CT. This is on FLAIR image, but of course also on T2 images, and on T2 we can see the low signal of some types of calcification indeed. The third syndrome is Sturge-Weber, or so-called encephalotrigeminal angiomatosis. This is quite interesting one because this is some type of venous drainage dysplasia, and then venous angioma and choroid plexus angiomas, which are due to venous obstruction. So it's the image is quite different, and clinically the patients have seizures and mental retardation, hemiparesis, and glaucomas, etc. But concerning the imaging, we see just a sequel of a malformation, not just the malformation itself, but the first thing, important and most typical is calcification, is cortical calcification, as you should see on the X-ray, if you do the X-ray of the skull, which is quite useless then, but of course on CT, we can see the calcifications which are coming from the occipital region towards the frontal region, and is associated with brain atrophy. So it's really typical. On MR, we do not see the calcification itself, but we see the dilatation of the ventricles in the atrophy, and we can see the low signal on T2 images from the dilated veins, and of course we can see those veins on digital subtraction angiography, but it's of course not necessary to perform this imaging method here. The last syndrome is von Hippel-Lindau, also called retinocerebellar angiomatosis. Its typical tumor here is hemangioblastoma, or hemangioblastomas of the central nervous system. This is concerning neuroradiology, but there is second thing, and because it's multisystemic diseases, as the other syndromes, we should have cyst angiomas, but then we should have bilateral renal cell carcinoma. So it's really important and should be very dangerous for the patient. So sometimes it's done the bilateral nephrectomy due just to prevent the patient from the renal cell carcinoma. Concerning the hemangioblastoma, it's a capillary type by WHO, first grade. It's not in children, just in adult patient, and typically, of course, cervicocranial junction, posterior fossa. But important is that we should see the cyst and very small nodule, but 1/4 of the patient should not have the cystic portion. So keep in mind this. But if you look at the posterior fossa, this case, large, huge cyst, almost on both sides. But after the contrast, see a really, really small nodule, which is important. Just apply the contrast and look after even small, few millimeters nodule, because this nodule is this important and should be removed surgically. This is another case where the cyst is quite large on T2 and of course on T1 image indeed, and the post-contrast, the solid portion is a little bit bigger, so it's nice. Not problematic to detect, and this is coronal orientation of the same patient. And of course, not just the posterior fossa, but also the spinal canal and spinal cord. However, the spinal cord is much smaller, so that means the cyst itself should be smaller, and the nodule, enhancing nodule, should be smaller indeed. If you look here, the nodule has something like 2 or 3 millimeters, same in this case. So that's why the application of the contrast agent is really mandatory on those cases here also. And that's my last case here for Hippel-Lindau disease. As I mentioned, 25% of the patients should not have the cystic portion, and this is case with 2 angioblastomas or 2 lesions on T1. Weighted image is T2, some peripheral edema, and after the contrast, really intense enhancement, and some small cysts may be here. So differential diagnosis should be maybe meds. Should be, yes, but the enhancement is really high. We can see on non-contrast T1 images some vessels around, some really dilated vessels, also on T2, of course. And then if you look at the spinal canal, we can see the cyst. We can see the small enhancing lesion here also. So that's in the differential diagnosis still should be meds, but in the first place it should be von Hippel-Lindau syndrome, and we should look for the patient history, for the other organs involvement and other things in this syndrome which should be present. So I got a few take-home messages. First of all, those phacomatosis are quite rare, but imaging is really important, and it should happen that's the first evaluation method of the patient, so we have to be aware of it, and we have to know at least the most common thing, most common types here. And if we image the central nervous system, of course, with MR, we should always use a contrast agent. As you have seen, there should be many tumors, some of them very small, so the application of the contrast should be absolutely mandatory here. And if you see the multiple CNS benign tumors or multiple CNS tumors, try to look at the patient, try to look at him, try to ask him, try to look at the history, because those things really should help your differential diagnosis and your discussion then on the indication seminars with the clinical doctors. And of course, look at the other organs. Look at the skeletal lesion. So if you have a CT, or you should do CT maybe then, and look at the other organs, look at the abdominal organs and other, because there should be really a lot of different tumors, a lot of different involvement, which sometimes should be more important than the involvement of the central nervous system. So I got a few references here. You can find it all around the literature, just reviews, and also a lot of papers, even of some rare syndromes. But in the big books, there are all of them quite nicely described, so you can look at it. Thank you for your attention.